right, guys, it's Lauren here, and I am with Dr. Emily Levy. And I'm going to let her explain what she does and how she got to this point in her career. And then I'm going to pick her brain for all of us.
Yeah.
Well, thanks for being here, Dr. Levy.
Thank you so much for having me and reaching out and having your team contact me. I love being able to do this kind of thing and share, collaborative effort into treating patients and getting people better.
Mhm.
I am a dentist. My practice is the TMJ Sleep Therapy Center of New Orleans. And so
Mhm.
it's me, and I work with my dad also. And
Mhm.
we treat adults and children for sleep breathing disorders, TMD, primary headaches, and craniofacial pain. So
Okay.
the whole spectrum of what that entails, right? So um, tongue ties, myofunctional therapy, early intervention orthopedics, orthodontic care with a certain system
Mhm.
that we've been using now once people are stable. And then for in kids, and then for adults, we still can, change teeth and affect those types of changes too. But really, it's more about stability of the jaw and stability of the airway. And most adults are like, please don't redo my whole face. Please don't make me have surgery, right? Please just stabilize me the way I am because I'm
Right.
here. I'm okay with this. And so we treat adults and kids a little bit differently because in kids, you make a ton of change orthopedically and even orthodontically at some points because they're growing and it's easy to do and you're doing it anyway. So you might as well do it properly when you're doing it.
Right.
But for adults, it's more of a stability and a healing of the orthopedic dysfunction and a healing of their pain. And so getting them to sleep. So I actually got, when I graduated dental school, my dad had already taken the courses from our mentor, Dr. Stephen Olmos, who's world renowned in
Mhm.
this field and in this space. And he founded the TMJ and Sleep Therapy Centers International. And the point of becoming a center was that he knew he could only reach X amount of patients
Right.
in his office, right? Like you can only
Right.
treat the people when you're physically in the building that live by
Yep.
you.
Mhm.
And so it became this effort to promote this thought process
Right.
by allowing other people to become what we call centers of excellence. And so
Uh-huh.
there's, I think, over 80 of us now
Oh, wow.
in 9 countries. And so
Wow.
we all practice the same standard of care when we're talking about these issues and we're talking about, you know, the kids versus the adults and how it overlaps, how it doesn't, how sleep and
Right.
pain are very much related, and how it's all related to your general quality of life, whether that's your energy levels or your mental health or your physical stamina. And so he started these centers and started training other people so that in different pockets of the world we're all doing the same thing to help the people locally to us. And so it's just
Right.
an exponential of difference in being able to reach that population, the people who don't sleep or the people who hurt all the time. So
Mhm.
from that, we joined right before I graduated dental school. We became a center, and so once I was graduated in dentist, I decided, okay, I'll go take that CE, and we'll see, what I want to do with it.
Right.
One thing led to another, and after having treated adults, my own kids had problems, and
Mhm.
there was no one who was treating the way that we treat in this area.
Yeah.
And then there was really a lack, and there's different thought processes on how to treat kids, but there was no one who was doing it this way really in the world. So we
Wow.
said, okay, you know what? We're going to hone in on that because if we can catch these problems when people are small, then they don't show up to
Yep.
us as adults with the same level of pain or the same level of dysfunction. And so that's really where you can affect the greatest changes in kids. I mean, you can still obviously treat
Right.
adults and help heal them and all those things. And there's testimonials all over our website about it. But the most rewarding thing you can do is change a child's life.
Right.
And so they don't have those problems. And so it was really born out of a necessity with my own kids. And then
Mhm.
I started figuring all of that out. And so now I'm blessed enough, it's the best part of my career. I'm blessed enough to teach the only hands on live patient pediatric airway course in the world. Uh,
Wow.
so we do that at our office. And I teach other doctors from all over the US and Canada. We have not had somebody cross an ocean for it yet, so fingers crossed. From all over the US and Canada, for how to treat these kids, how to intervene when they're young and develop them so that we can eliminate a lot of these problems. So it was
Okay.
really born out of necessity in my own life. But then
Yep.
once I started doing it, I was like, well, it's the same concept, like with Dr. O, making the centers and saying
Yeah.
we need to have more people treating patients this way so we can affect more of them. And so now there are many people, I mean, I'd have to look at the list, but many people who've come through our course and now go home and implement. And that's
Mhm.
really a beautiful thing for their communities. And so I teach that through TMJ and Sleep International. So
Okay.
TMJ and Sleep International has courses on mini residency on adults, this pediatric mini residency format course as well that I just mentioned, as well as a few other different courses for just how to triage pain, how to orthodontically change things once patients are stable. And so we're trying to affect educational reform because
Mhm.
um, that's really the problem is that you have to go post grad to get this information, right?
Yep.
You don't get this in school. So that's kind of how I got here. And now, I mean, I was telling you a few minutes ago, I'm just humbled by where my career is because like a decade ago, graduating school, I would have quite literally never that this is what I would be doing. But I'm so very grateful and
Yeah.
grateful that God got me to this point because it is by far the most rewarding thing that I've ever done
Yeah.
as a career, in my career. Outside of my kids and my husband, this is up there. And so I very much am humbled by the fact that we've got people coming from all over the Southeast to see me, which is just bananas. But it's so very humbling that they believe in this enough, and they believe that their kids have airway issues that need treating, and
Yeah.
it just furthers the mission though of okay, well, while I'm grateful that people would fly from other states to see me, I also it motivates me to continue spreading the message so that maybe
Yep.
somebody in their state who is
Mhm.
to them geographically would start doing this and start
Right.
start seeing not just that one family, but hundreds of families. And so yeah, that's how we ended up here.
It's interesting, like, how many because I have a kinda similar I've had a similar journey in my career where it's, like, been born out of necessity for my own kids, and it's funny, like, how many of us in, like, the medical world, who are kinda operating in, like, I guess, like, non-conventional or non-traditional zones,
Mhm.
it all comes from, like, personal experience, and realizing, like, I don't have no one to go to help me for this, so I guess I have to learn how to do
Have to
this now,
figure it out figure it out for
Yeah.
myself, and
Yep,
in
yep,
a way, your patients benefit from that,
yes.
right? Because I was laughing with a patient actually like a couple weeks ago about my oldest, and I was like, yeah, I tried this on him, and they were like a guinea pig, and I was like, well, kind of. Like, 'cause I wanted to see what would happen, right? So that
Yep.
if it worked the way I wanted it to, then I could use it for other people. So, guinea pig maybe is the wrong word, but it gives you, necessity is the mother of invention, right? And
Yes,
so, being able to see what's lacking in your own life or your own kid's life or your patients' lives and being like, okay, there's got to be a better way.
yes,
Got to
yep.
be an easier way, a more holistic type approach to letting the body try to heal while we're correcting the dysfunction.
So walk us through, like, what are some of these interventions that you do?
So it depends on, like I said a minute ago, it depends on age. So in children, we are trying to grow them out of whatever dysfunction they have as best as we
Mhm.
can, right? And some things you can't 100% get to go away, but for the most part, you don't always take every kid from a 0 to a 10, but if you get them from a 0
Right,
to an 8 or a 9, like that's pretty darn good, right?
right.
And so, especially medically, the medical model, that's what we have to think about. And as dentists, that's a very difficult concept for a dentist when we're talking about treatment options because dentally, we are trained to have like a 95% success rate in everything we touch.
Uh-huh.
And so when you're talking about a medical model, it's a little bit different. And so as dentists, it makes us kind of nervous, right? Because
Yeah.
it's like, well, if I can't be perfect, then I'm a failure. And it's like, no, no,
Right.
no, no. When we're looking at it as a quality of life perspective and from a medical model perspective,
Mhm.
that's a way lower bar,
Yeah.
which is a
Yep.
shame. Okay, that's a shame, but it's a way
Yes, it
lower
is.
bar. And
Mhm.
40% improvement in symptoms is a success medically. Um,
Yep.
and that's still mind blowing to me, but it's a different mindset. And
Yeah.
so I don't settle for 40, but when we're thinking about how to treat patients and decreasing their inflammation and managing their nutrition and orthopedically stabilizing them, we have to determine a what are their chief complaints first and foremost,
Mhm.
right? Because if a patient comes in and they're complaining about things that technically I'm not going to be able to fix, then
Right.
that's not my purview, right? Um, but depending on what their chief complaints are and depending on what their goals of treatment are. So I have from adult, let's say I had an adult come in this morning, actually, when I was seeing patients this morning. Um, and she has pain all over her head.
Mhm.
And so we triage similar record collection for adults and kids, but we triage pain based on an orthopedic test that we do from a motor nerve reflex response. And we say, okay, what
Mhm.
is your brain's priority of this pain? Because you might hurt a million different places, but your brain doesn't care about all of those things. Your brain is having one main problem and then a
Right.
bunch of other problems. And that's what puts you
Right.
in, a fight or flight state, a sympathetic dystrophy. And so
Mhm.
when we're talking about management of inflammation, management of the nervous system, we have to figure that out. So our data collection for adults and kids looks like muscle palpations of the head and the neck, where we push on different muscles and ligaments and see what the visceral response is. Motor nerve reflex testing to see what is the brain's priority of whatever pain they're complaining about. Is it actually coming
Mhm.
from the place it hurts or somewhere else? Which in chronic pain,
Right.
it usually isn't from the place that it hurts. That's
Right.
usually not the source. We do a joint vibration analysis. We do a rhinomanometer to measure the airflow through the nose. We do a CBCT scan. We take postural pictures, intraoral pictures, an intraoral exam, an extraoral exam. I mean, cranial nerve exams. So much data goes into a diagnosis. And then again, depending on age, we decide, okay, are we an adult and are we managing this? Are we saying,
Mhm.
okay, like my patient this morning, you have in the vernacular TMD. Okay, but that's not a diagnosis. She had disc displacement with reduction. She had facial and cervical myositis. She had capsulitis. And so that's what I'm treating. But I'm treating to a normal range of motion and a reduction of pain for an adult.
Okay.
Um,
Okay.
or if they have a sleep issue, improve sleep. And
Right.
so from an objective and subjective perspective. So in an adult, I use a series of orthotics to manage that. I'm not trying
Mhm.
to change all the bones in their face. I'm not trying to make anything different dentally. Teeth position has no bearing on any of this. This is
Okay.
strictly just here is an orthotic to neurologically stabilize this in a position where your brain is comfortable for your jaw, your airway is stable, and then we let it heal. And so adults are, like I said, a little bit different. In kids, we do all of those same data collections and record collection, but when we're putting a treatment plan together, it's with growth in mind because
Okay.
all 99% of children are underdeveloped. And so
Yeah.
what happens is, especially post-industrial revolution, and so what happens in kids is they go see the pediatrician or they go see the dentist or the pediatric dentist, and they are only looking for decay or parent reported symptoms.
Okay.
And so you go to the pediatrician, they're like, here's your height and weight. And any complaints, mom? And mom's like, oh, well, we're 5 and like we still not sleeping, but ha ha ha. Like it's just, and it becomes this like gag instead of a further dive into
Yeah.
why aren't we doing these things, right?
Right.
Um,
Right.
and so there's a whole population that's missed, and it's in kids.
Yeah.
And the problem too is they have pain like adults do. They don't sleep well, but their life experience is only this big. So it's not like they're 40
Right.
and they're like, man, we didn't feel this way when we were 20. They're 5,
Right.
6, 7 years old. They have nothing to compare this to.
Mm-hmm.
So in kids, when we take all of that data, parents are generally surprised to be like, oh my gosh, I didn't know their head hurt. Or I didn't know they had these issues, and they feel bad because they're like, they never told me this. And it's like they wouldn't because
Because they don't know how to.
they don't know, they think it's normal. They don't
Right.
know that that's weird. Um,
Right.
and so when we are treating kids, we use and it depends on what we're treating, but different types of appliances to help grow that kid orthopedically. And the reason
Okay.
is because in a sleep breathing disorder in children, Dr. Christian Guilleminault, who was a giant in the field of this, said in non-obese children, sleep breathing disorders, obstructive sleep apnea, is a disease of dental facial orthopedics.
Okay.
Where are the bones? And again, post-industrial revolution, the air we breathe, the food we eat, how we function is not enough to grow our bones
Right.
properly. And so
Right.
what happens is these kids are overlooked for so many years. And then they're 12 and somebody says, well, you should go get braces. You should go to an orthodontist and get braces.
Mm-hmm.
The orthodontist is only straightening the teeth. They're not looking
Right.
at function. And actually, and this is going to ruffle some feathers, but it needs to be said.
Okay. Say it.
The American Academy of Orthodontics and Dental Facial Orthopedics has published articles saying that, yeah, we know that fixed retainers don't work. We know
Wow.
that 100% of cases are expected to relapse within 8 years. And we also know that orthodontists are terrible at noticing mouth breathing.
Wow.
And so it's like, okay, well, then if all you're looking at is teeth and you're not addressing the function, and then they're 12, 13 years old, you've missed a critical part of their childhood and development where their IQ changes, their anxiety and depression,
Absolutely.
their oppositional defiant disorder,
Mm-hmm.
ADHD diagnosis, right? So many things that affect their day to day, especially in school, have been completely overlooked. And so the way I explain it to parents is like, okay, well, what is the primary function of life? Breathing. If you can't breathe, you'll be dead pretty quick, right?
Right.
And
Right.
so if we're overlooking that primary function and we're just like, well, we're going to, straighten up these teeth for you. And then Johnny's 25 and he's getting married in a year and he's like, man, my teeth are crooked again. Maybe I should do it twice. It's a good business model, but it's not functional.
Right.
Yeah.
It's cosmetic.
And so when we talk to parents, it's like, look, breathing is a primary function of life. So what if Johnny couldn't see? Would you
Yeah.
wait until he was 12 to get him contacts, or
Mm-hmm.
would you give him glasses when he was 6?
Right.
And the answer unequivocally is, well, certainly you'd give him glasses. You wouldn't let him not see. And it's like, well, okay, good. So we're on the same page in that breathing is even more important, and we're not treating that. And so what we
Right.
see as kids grow is typically 98%, 99% of the time, a craniofacial pain problem, a jaw problem,
Mm-hmm.
is predisposed by a breathing issue, whether it is a
Okay.
functional breathing issue or a sleep breathing issue. Any breathing problem is going to change the head posture, change the way the muscle relationships interact, and then create a series of micro traumas to the jaw.
Wow.
And
Okay.
everybody's adaptive range, as you know, in your field, is different, right?
Yeah.
We all have a
Yep.
different adaptive range for what we
Yep.
can tolerate and what we can't. And so over time, though, as the adaptive range gets smaller and smaller and smaller, and those micro traumas continue, then we have legitimate orthopedic damage. And so that's what we're trying to prevent in kids too. And like I said, we can treat all of this concurrently. So it's not like,
Yeah.
oh, well, we've got this one airway problem. When we're treating these things, Dr. Olmos actually wrote an article on this that we lecture on all the time. And it's when you are treating sleep disorders and craniofacial pain, you have to look at them as a unit and
Mm-hmm.
the symptoms as a unit, because you can't start pulling out. People in pain have a whole lot of daytime symptoms, but when they go to bed, it doesn't get better.
Yeah.
And you can put way more force on your teeth when you're sleeping, especially if you're in pain, than you would ever be able to do when you're awake. But then what is that doing to your airway? And if your airway was the source of the pain in the first place, we need to fix them at the same time.
Right.
So that's what we're doing. And so kids' appliances look a little bit different one way or the other. And a lot of parents have experience or knowledge, I guess, of expansion techniques. But what we find in children with obstructive sleep apnea, especially, is that yes, there is good research and literature on what happens when we expand a kid with breathing issues. There's great literature on
Mhm.
that. But how much more profound would it be if we did it in a three-dimensional way? Because that's really where they're limited. And they're not, if they're not
Right.
growing in one dimension, they're certainly like growing in three dimensions.
Uh-huh.
And so what we're finding in kids is that it's a much more profound, much more efficacious treatment to not only grow a kid, side to side, like if people have an experience with expansion, like traditional expansion, but also grow them forward and vertically. And
Wow.
so the vertical dimension is actually the most important because we're doing that same neurologic position that I talked about in the adult orthotics to stabilize the joint, stabilize the airway. We use the same thing in kids. But in kids, I can grow them to that position and then they're there forever. And so,
So is it literally something that, like, goes in their mouth while they're sleeping?
and sometimes during the day, depends on what we're doing. Depends on what
Okay.
we're doing.
Okay.
And then all of our therapy is adjunct therapy as well as a part of treatment. So laser therapy, low level intensity laser therapy is supremely important in the
Okay.
decrease of inflammation, but also in bone growth. Um,
Mhm.
and so, yeah, we can decrease inflammation by like it's even faster now because I just got a new laser that goes faster. It's more powerful, but at a minimum 50% in 90 seconds. But it helps with bone turnover because normal bone activity and anti decreasing inflammation, I guess, when the bone is developing, is going to be helpful for efficacy and speed. Right? I'm
Right.
not looking to rip apart cranial sutures. We're not looking to create scar tissue with rapid expansion. Everything we do is with normal bone turnover in mind, and
Uh-huh.
because otherwise you're fusing other things and you're creating scar tissue other places. So it's all a very delicate process, not a painful process for kids, a very delicate process to get them kind of redirected back onto
Right.
their normal, what their growth potential would be.
Right.
Yeah.
So, okay, do you have, in terms of, like, the children that you see,
Mhm.
okay, is this, like, the parents coming to you and saying, like, "I know my kid has a sleep problem, help me," or is it like, "My kid has all of these issues, anxiety, depression, ADHD, behavioral issues, and we've tried everything else and we don't know what else to do?"
Both.
Okay.
Both. So what we find, I lectured on this actually on Friday last week. What we know to be true is that a lot of children are having behavioral issues in school as a function of their lack of sleep or lack of
Right.
quality sleep. I should say quality sleep because some kids are in bed for 11 hours, but
Uh-huh.
their quality sleep is poor, right?
Right.
And so what we see a lot of is misdiagnosis of ADHD as probably
Yeah.
the main top offender
Mhm.
is that these kids are being misdiagnosed as ADHD when really they're exhausted. And
Yeah.
kids don't act exhausted the way adults act exhausted, right? We drink a cup of coffee in the afternoon, we go take a nap. They're unable to do so, and so they have to
Right.
distract themselves at school where they're supposed to be for 8 hours a day. And then they become a classroom disruption. And then the teacher's like, "Mom, your kid's not sitting still on the desk. You need to go get them evaluated for ADHD." And that's how the diagnosis is really being made.
Yeah.
But there's a significant percentage of those children who don't have ADHD at all and
Yep.
actually just can't breathe. And so we've treated kids who have been able to discontinue their ADHD medication because they're restored when they wake up in the morning.
Right.
And that's huge. The other thing that the centers have found, and there's a paper hopefully being published within the next few months on this, but I can tell you at least the findings from the statistician, and that is because that's the other thing. The centers kind of put together data from all of our
Right.
this is part of research. So we use the GAD-7 and the PHQ-9 for
Mhm.
anxiety depression questionnaires, and we take one in the beginning of treatment and then we take one at the end of our active phase of treatment for adults. And in adults, an active phase of treatment for a pain is 10 to 12 weeks. So beginning and then 3 months later.
Mhm.
And there has been, regardless of male or female, there has been a statistically significant decrease in anxiety and depression scores just by getting people out of pain and getting their airway stable.
Wow.
And in 3 months, right? So that's huge.
Huge.
But we know that the same thing's happening in kids.
Yeah.
per parent reporting and symptom reporting. We also use in children the PHQ. So the PHQ is a validated sleep questionnaire for kids, and it goes
Okay.
through nighttime symptoms, it goes through daytime symptoms, and then it goes through behavioral symptoms. Um,
Mhm.
and when kids are, we don't tell parents when they're filling it out how many
Yep.
is kind of the cutoff for like a red flag. Because we also have to use our clinical judgment because I don't want to bias them into being like, oh, well, is it this or is it that? I don't want them to be over the limit,
Right.
because I'm not going to bias people. But when we're reviewing that, we also have to use our clinical judgment, looking in that child's mouth and saying, okay, I see a Mallampati score, the amount of the airway that I can see, of 4. I see enlarged tonsils. I see a high vaulted palate. I see a tongue tie. I see a cross bite. I see a deep bite. And so putting together the puzzle of what's going on. And I mentioned tonsils, but I should make this caveat. I'm not advocating for tonsillectomy and adenoidectomy. I should make that
Yeah.
caveat, because the research doesn't support that as a valid treatment option for either apnea or the subsequent behavioral issues that come from it as a long-term solution. It's not that 75% of kids relapse 6 months to 3 years later. So that's not,
Okay.
yeah, that's not, I'm not advocating for it, but it is an alarm system that I would look at and say, okay, if we develop this kid, most of the time those tonsils are going to shrink down because we're affecting the function of why they were enlarged in the first place. So I did have to throw that caveat in there because so many kids I see are on their second and third round of tonsillectomy and adenoidectomy, and they're not better because their function wasn't addressed. We just removed body parts.
So wait, why in that situation, like why would the tonsils be enlarged?
So when we are not breathing effectively through our nose and our airway is crowded, our upper jaw is crowded, our tongue is low, the tonsils and adenoids tend to be more inflamed because they're becoming the first line of defense for filtration of air.
Oh,
So
okay.
once we develop kids, I have a case. Actually, I showed this case. I'll give you all the website at the end. I showed this case in my webinar Friday that I did. And in 2 months, 2.5 months, his tonsils went from like a grade 3 to a 1 plus.
Wow.
So because we grew his face,
Right.
and so he didn't need surgery. I also have lasers and stuff that can help, disinfect the soft palate and whatever. But really, it's the growth. It's the growth of the maxilla that changes the game, and that's what we see over and over and over again. Because for every 1 millimeter of development I get in the maxilla, I get a 2.35% increase in nasal volume. And then
Mhm.
that increase in nasal volume changes the flow of air to the fourth power because it's a tube, so
Wow.
it's exponential. And so, yeah, that's so much more effective. And the kids need to grow anyway, because like I said a minute ago, if they've got a breathing issue, it's an orthopedic problem, right? It's
Mhm.
a facial orthopedic problem. So um, it's just a different mindset in how to treat. And then when you're done, like I said, adjunctive therapies, laser therapy is included, but I am so very blessed to have in my office. She actually was a patient that we treated as an adult for TMD issues. She had nasal anatomy that she had surgery for. She had a pretty significant tongue tie, which wasn't her issue anymore. Once I fixed the other stuff, we really didn't have to release it, except she's a speech therapist. And so,
Oh,
hey,
wow.
would you mind letting me do my job better? And I was like, yeah, sure. So that's reasonable. So we treated her, and then I've done some functional orthodontics with her. But after she was kind of going through this whole process, she was like, I would love to work here. And I was like, fantastic. I would love to have you. So she came on as a speech therapist, but also as a myofunctional therapist. And so every single kid who comes to our office, if you're starting orthopedic treatment with us, you're also getting myofunctional therapy. And so what
Wow.
myofunctional therapy is the retraining of the lips, the cheeks, the tongue, the swallow pattern, and most importantly, nasal breathing. Because Dr. Christian Guilleminault, the one I mentioned earlier, he said that's how we know we're finished with
Mhm.
is when we've restored nasal breathing for these kids. That's how we know we're done.
Mhm.
Because that's a physiologic way to breathe, and mouth breathing in any form is pathologic. And so what we're finding and what we're seeing is that these kids who go through myofunctional therapy in conjunction with orthopedics not only move faster through the whole process, but because of the habit correction and because of the airway corrections and the chemoreceptor retraining that we're doing, they're more stable long term.
Right. Right. Um, okay, can we talk about tongue tie really quick, for selfish reasons? Because my my oldest has tongue tie.
Uh-huh.
Um, and I saw a oral maxillofacial surgeon, when he was an infant,
Hmm.
and he determined that it wasn't severe enough to intervene. And I always second guess that. He is super bright, very well behaved, but he has had, and I don't know if this is related at all. He has had severe allergies like every single day of his life since he was a baby.
That is related.
Um, okay. I've started to think about it. And then there's also like, you know, I love him. I don't care what he looks like, but I think that there's a cosmetic component as they get older,
Mhm.
you know? So, okay, so you feel like that is probably
So allergies are just related to a lack of functional breathing
okay.
or severity of. I mean, you can be allergic to
Yeah.
stuff, obviously, but severity of allergies. Usually, we see kids have less of that issue once we develop. Not that the allergies necessarily mean, especially food allergies. Like, okay, well, if you're allergic to, shellfish, you're allergic to shellfish. Like,
Right.
but from like an environmental perspective, just a better
Yeah.
filtration of air through the nose is obviously going to be helpful for that. But from a tongue tie perspective, so I actually saw a baby yesterday who was 3 weeks old, and this just comes to mind because I usually see tongue tied babies on Tuesdays and Wednesdays, like if
Mhm.
born or whatever. So yesterday was Wednesday, so I saw her yesterday, and her mom actually is a dentist, and we had some mutual friends and whatever, and so she came in and she said, my pediatrician said this was probably fine, and my lactation consultant said this is probably fine, but she's 3 weeks old. We've already been hospitalized for failure to thrive, and
Wow.
they were like, "Well, she'll be okay." And I'm like, "Okay." So we go through. It'll probably stretch on its own, pop on its own, whatever. I'm like, "All right." So we go through all the symptoms and baby symptoms, mom symptoms, because she's part of that group
Yeah.
too, right? Um, And I was like, okay, I'm gonna just take a look because we talk about all the symptoms and the function first, right? Because it's not just anatomy; it's also the way that things move. And I have a
Right.
speech therapist there who does the feeding therapy for these babies, and so she said the baby started crying for a second, and so mom rolled her toward her, but my speech therapist had a better view, and she was like, "Oh," so just she's done that. So I was like, "Okay." So we go, and I go to look in her mouth and look under her tongue, and when I tell you, this was probably one of the top 5 most obvious tongue ties I've had in my
Wow.
career, and that's what's happening, right? That's what's happening is these kids are getting overlooked, and moms are like, that people are telling me you're normal. They're normal. Everything's normal. Babies have certain symptoms. And it's like, no, not if there's a physiologic problem, right? And so what I find with tongue ties is this. I actually also teach a course on tongue ties for a laser company, DECA,
Mhm.
which is a subset of Ellen, the world's largest laser company out of Italy.
Mhm.
And basically, not every tongue tie needs to be released
Okay.
um, in order to gain function.
Okay.
It's a give and take situation. And what I find is in infancy, that is the biggest bang for your buck in getting kids' tongues up and getting them feeding properly and whatever. But as
Right.
we grow and as we age, that's not the only problem anymore. And so my issue with a lot of release providers, I actually got my fellow in orofacial myology, so I could say this without people saying I didn't know what I was talking about. Because you say stuff and they're like, well, you're not educated. And then I'm like, no, I did it.
Yeah.
And I'm telling you, I think this is crazy. Is that we get so myopic on tongue tie being like the end all be all cure all.
Yeah.
And the older we get, the less of a problem a tongue tie is. And what I
Okay.
mean by that is not that there are not tongue ties that are a problem when we have older children or adults, because there certainly are. But it is not at the same frequency as in infancy where that would make a huge difference to release.
Right.
And because everything else has had years to grow. And
Mhm.
everything else is a problem. It's still
Yeah.
a problem in an infant because that bone tongue relationship has been growing for 8 months pre-birth, so it's still a problem. But as we get older, for instance, in adults, if an adult comes to me and says, "Hey, I think I have a tongue tie," I have only in my career treated a singular adult who only had a tongue tie and did not also have a sleep breathing disorder or TMD.
Wow.
One. So if
Wow.
I only release tongue ties, or I'm only looking at tongue ties and I'm not looking at symptoms and objective data from a CBCT and doing my triage that we talked about at the beginning, well, then I'm missing like the forest for the trees, right?
Yeah. Yeah.
And so on the flip side of all of the adults that I have treated in my career, the amount of adults that I have had to release is minimal
Huh.
compared to the adults that we treat. So
Okay.
I see because once you fix the breathing and once you fix all the associated musculature and once you calm the nervous system, those things get better
Yeah.
and they're not
Yeah.
compensating the same way. And so that's not to say that some tongue ties in kids and adults don't need intervention, because certainly that happens. Certainly sometimes you plateau in symptom treatment when you're getting their subjective data and they're like, okay, I'm kind of plateauing here, I haven't noticed a big difference in the last month or two. Okay, well then, like, let's look at some of those other things, and that's when we incorporate, especially for the adults, more myofunctional therapy. The kids are getting it anyway.
Yeah.
But to figure out, are we capable or are we not? But in infancy, that's really the best thing you can do if you see a tongue tie in an infant is, okay, let's get you therapy, always feeding therapy, always body work for tongue ties, because the tissue of the tongue runs all the way through the body to the big toe. And so you can have different pulls and different fascial tensions that are affecting the movement of the tongue outside of
Right.
just the tongue itself. Um,
Uh-huh.
and so all of that is important. And I never advocate for releasing a tongue without the appropriate therapy and working with a team to figure out timing and readiness of the patient. But in infancy, that's really mostly what you can do because
Yeah.
they're a baby, right? And they
Right.
have to be
Right.
able to eat properly and effectively. But once you grow, it's like, okay, well, it's more to this. And
Yeah.
like I said, the amount, I would say probably 75% of my adult patients are tongue tied. I do not release 75% of adults.
That is crazy that the incidence is that high.
Well,
And do people know that they're tongue-tied or
not all of them. So you got to look at my patient
okay.
population too, right? Like, this is what I'm treating
Yeah.
and seeing every day.
Right. Right.
So my
Right.
incidence of seeing it is going to be way higher.
Yeah.
But the if I just released all the tongue tied people that came in, I would fix maybe 5% of their issues.
Right.
And so that's the thing. And I like I said, I think the tongue tie community, the release community, myologists get very myopic in that that's just going to be this magic wand cure all.
Right.
And so as a provider, I find that frustrating because it's just not true. But it's
Yeah.
just as a person in a community, it's like we're giving people kind of wonky information,
Right.
or unrealistic expectations of like what actually
Right.
can be affected by this tissue versus now that you've grown, what else is actually underlying it. So, like I said, of all the adults I've treated, only one did not have a sleep breathing issue or
Wow.
a craniofacial pain problem in conjunction. And I knew she didn't have a sleep breathing issue because when I saw her and she didn't have facial pain, I sent her for, she just had some neck tension, which is a common referral of pain from the jaw. So I eliminated that though. And I was like, okay, I don't think that's your issue. But I sent her for a sleep study anyway, because again, those are intimately related and we have to know
Right.
one or the other, and came back normal. So I was like, all right. All right. Well, then I guess you're just one of those unicorn people who made it to adulthood without some other crazy thing happening.
Wow.
And she was a CrossFitter, so she wanted more, shoulder range of motion and some of that tension
Right.
was affecting it. So that was her motivation. But I mean, I just don't see, I don't, even the kids that I see that are tongue tied, I don't release every single one because it's not,
Right.
once we're fixing the orthopedics and the airway, it's not 100% necessary all the time.
So is the issue that like the baby's born with tongue tie, and so then their mouth and their face develop in a certain way that causes other problems, or they're born with a tongue tie and born with some issue with their
That's
airway?
a great question, and I'll give you the how a tongue tie is formed, and then I'll tell you my own personal experience with my 5-year-old.
Okay.
So, the tissue under the tongue forms 6 weeks in utero through
Mhm.
apoptosis, right? Programmed cell death to differentiate the moving body of the tongue from the floor of the mouth. And
Okay.
so 10 weeks in utero, the palate is formed, and that tissue is supposed to work together pre-birth.
Mhm.
And the way that the palate is supposed to grow, like in our ancestors, for instance, the way the palate is supposed to grow is a combination of the tongue pressure and the nasal airflow, squishing the bone and helping it grow side to side and forward.
Okay.
When a few hundred years ago, like pre-bottles, okay, when the only option was to nurse, um, all the midwives would have a sharp nail and they would run that nail under a newborn baby's tongue.
Ooh.
They didn't do a functional exam or any kind of crazy.
Yeah.
They were like, "This is what we have to do because if this baby can't eat, we're
Yeah.
gonna have a problem," right?
Ooh, God,
And
that's awful.
so, but it was effective
It worked?
because
Yeah.
our faces grew, right?
Mhm.
And so whether or not they had a tongue tie at that point was kind of irrelevant because they weren't figuring that out. They were like, "You got to nurse
Yeah.
or you're going to die." Like that's the option we
Yeah.
have. We don't have
Wow.
we don't have NG tubes or bottles or whatever, right? And
Right.
so the kind of evolution of that, I guess, in today's world is that we do have alternatives. And
Right.
it's easier for tongue-tied babies to bottle feed typically
Yeah.
because of the way that the milk is transferred. But the way that the face is also supposed to grow is the act of breastfeeding. And so if we can't get the tongue elevating properly, which is really the motion that we need, if we can't get the tongue elevating
Mhm.
properly, then something in our bony structure is going to be off. And it's
Yeah.
usually you can tell at birth that they're a little more narrow, their palates are a little more cathedral ceiling, less superdome ceiling.
Yeah.
But for instance, you were like, okay, is some of this, um, as they grow, is this a problem? In the case of my daughter, and this is something that I tell parents when I see them with newborns. In my third child, she's 5. I did everything right. Okay,
Mhm.
because by then I was like rolling in doing this, and I was confident that we were going to make better choices every time we
Right.
had a kid, right?
Right.
And
Right.
so you know better, you do better, and so she did bodywork therapy, feeding therapy, lactation. I released her at a week old. Did
Mhm.
all of our follow up therapy. I breastfed her for 2 years.
Mhm.
She did some minor purees because they do have to learn how to like control a bolus and whatever, but mostly baby led weaning. She was chewing. The teethers we used for her were like, functional, myofunctional, oral motor type teethers.
Right.
I mean, we did all the things. She has apnea.
Uh,
So, do you know what I mean?
you can't
So, like,
100% prevent it.
you can do your best.
Yeah.
Like
Yep.
your
Uh-huh.
kids still may have a problem.
Mhm.
So, even though I got her function better and her speech is fine and her sleep was not, she really didn't have a ton of sleep symptoms. I found out she had apnea on accident because I was testing something else for my patients on my kid. So I
Wow.
feel like we talked about you use your kid as your test dummy.
Yep. Yep.
And so I was testing something for my patients on her and I was like, well, that's not normal. And so then I like actually tested her, but I'm like, no, that's she didn't really have any symptoms. And so while yeah, I think her airway's looking better now just because I'm developing her even more. I did technically, and I even started orthopedic development on her at 4. So like we did all the things,
Yeah.
but she's still got a breathing issue, right?
Uh-huh.
So,
Uh-huh.
and that's another, we did orthopedic development on her at 4, but it was really more linear because I was testing out a new product. So, I mean, like, we're back to that, right? And so
Swear my kid's not a
I
guinea
was
pig.
testing out a new product and I was like, well, she's 4. I still have time to fix it if it's not enough of what I need.
Mhm.
And it wasn't enough. And so that's how you learn, right? That's how you know, okay,
Yeah.
well, I'm not going to do that to a patient if it wasn't enough on my kid.
Right.
And so, yeah, now we're doing the three-dimensional stuff on her because even though I technically did a bunch of stuff from birth, she's still got problems, right?
Yeah.
Um,
Yeah.
and so I think that happens a lot of the time. And so I tell all of my patients that if they come in with infants, like, look, this is a help for them to feed, right?
Yeah.
To get nutrition. Like we obviously need them to gain weight and grow and all those things, get enough calories, but don't think that this is just some cure all.
Right.
Because some
Right.
providers will say stuff like that. Oh, this will prevent
Mhm.
issues. This will prevent airway issues. And it's like, it'll help reduce the risk,
Right.
but there are still very much bony structure things that happen and have already happened pre-birth that
Right.
are going to probably still need intervention. Like we're not just
Right.
releasing a tongue tie and expecting this kid to grow exactly the way that they're supposed to.
Right.
We live in an environment where that's just not possible. The food we eat in the air,
Mhm.
we make sure of it.
Yeah.
And so while some of this is genetic, really it's also epigenetic and the environmental factors that decide what genes are expressed, right?
Right.
And so that's kind of what we see is like, yeah, parents are like, oh, he just got his dad's mouth, or everybody wants to do that. Oh, he's just got his dad's jaw, dad's mouth. Okay. But really, even in identical twins, we see changes. There was a case that I don't lecture on this case, but I should get the slides because it's a good one to show how much function affects the form. It was
Mhm.
some identical twin boys, and they looked completely different. And the reason they looked different is because one of them couldn't breathe.
Wow.
So once they fixed his airway and they got him stable and fixed his breathing, he started to look more like his brother again.
Interesting.
And so, yeah, it's just the epigenetics of it all and what genes are expressed
So
based on your
interesting.
function. Yeah. So, and how the form changes based on your function,
Yeah.
based on the fact that your bones are going to do what the muscles tell them to do. Because if you put muscle against bone, muscle's going to win. And so we have to be able to counteract that with A, development, but B, then the
Mhm.
retraining of that musculature so that we're stable from
Right.
in a habitual way. So that's the goal, right? That's the goal is habitual stabilization.
Right. Right. Well, this is so fascinating. I would love for you to come back so we can like do a deep dive on
Sure.
another topic. And then I'm probably going to be calling you for my oldest child and
So,
possibly my middle child
well,
too.
we
um,
are here to help. Yeah, here to help and at least, do some digging into what's going on symptom wise
yeah.
and then objectively, of course, like I like when people come back and they say, oh, I feel better. Great.
Yeah.
But that's not data, right?
Yeah.
And
Yeah.
so if we're gonna measure stuff, that's what we like to do is measure a point A and a point B to know, okay, what's changing, what's
Right.
objectively different for this person. So yeah, that's what we do. I'm just grateful that y'all called and gave this some airtime because it's an important message. I think. I mean, I'm biased, but I think it's an important
Absolutely.
message. So I'm grateful you asked me to come.
Okay. Well, how can people find you?
So our website is tmjsleepnola.com, and
Hmm.
our Instagram handle is at TMJ Sleep NOLA. We're located in Metairie, just off a causeway by the Toyota dealership on the corner of 7th and Ridge Lake. Our number is 504-832-2222. And then from an educational perspective, if there's anybody who wanted like more information or access to certain webinars or to see what's up, TMJ Therapy Center, CENTRE.com is the TMJ Sleep International website. And so they have directories. Like if anybody's listening and they're like, okay, well, I can't make it to New Orleans. Like, where do I go?
Right.
Directories on there of where our centers are, and also just some educational opportunities, webinars, things that I've got coming up from a teaching perspective. I'm teaching for we didn't even get into this today, but a functional aligner system out of Italy. Doing that next month. So things that are coming up and new educational things coming out. So that's a good place to get some data too and keep up with whatever is the newest.
Okay. So cool. Well, thanks for being here. Appreciate it. And everybody go look up Dr. Emily Levy.
Thank you
Thank
so
you.
much.
Thank you for tuning in to this episode of the Little Brain Campaign podcast. If you enjoyed our conversation, give us a follow on your favorite podcast platform so you never miss an episode. Please take a moment to leave a review while you're still thinking about it. It really helps grow the podcast, and I love hearing from our listeners. See you next time.